Thank you very much. I must say I'm delighted to be here. I get thrilled really and so inspired myself to see young researchers or those interested in research in your own time coming to events like this. And I think for the Academy particularly, I think it's a fantastic idea, and I personally, of course, would always want to support such moves. Now, I've in fact been asked to talk about two things. The first is, well, my science and career story, and I do want to, I guess, alert you to the fact that listening to old guys talking about how the good old days were is sometimes not quite accurate. But I'll try and describe my story about why I did what I did and how I went about it in the first part of the talk. And secondly, perhaps more importantly, is how to both formulate and then progress a research question. Now, I am primarily a clinical researcher and therefore actually a clinical trialist. So what I do and we do as the Australian New Zealand Clinical Trials Network is large international randomised controlled trials addressing questions that we believe are important in both anaesthesia and broader perioperative medicine. And we've had a very successful track record over the last 20 years or so. And each of these trials have been funded by the NIHR and they've got into very high quality journals. So that'll be part of the story. But I'll take you back right now to when I was, first of all, a medical student and then a young doctor. And that is, well, you know, I actually developed, I don't know why, developed some interest in research. I think I was a questioning person. I was not satisfied with the status quo, the textbook knowledge that existed at the time. And like any younger person, when you start asking questions like why, or why is it so, why do we do this, most people you ask that get annoyed and just suppress you, but others engage and want to try and help facilitate new ideas, new knowledge. So what I won't spend any time on in my presentation is talking about motivation, a research environment or a nurturing environment and mentors. They are crucially important, but I'm sure you already know that quite well. I do want to emphasise just for a moment, and this is particularly for clinical researchers, and particularly for those who are doing or are interested in clinical trials, that one thing that was often missing, certainly in my education and training, including specialist training, was an actual proper understanding of statistics and research design and sources of bias and confounding. And I consider that one of the basic sciences of medicine or healthcare, and certainly for those who are doing clinical research. It's as important as physiology or anatomy or histology or anything else, I think even more so. And most medical research, particularly in my specialties of anaesthesia and the related specialties, the people doing the research were literally untrained, unqualified and highly biased. And the research was a waste of time and mostly misleading. And that infuriated me then, and it even more infuriates me now. So what I did in my training is that I did a standard medical degree. I wasn't that smart and I didn't do that well. I did well enough, but I had no ambition at that point to become a medical researcher or even a specialist, to be honest. But I was channeled into and fell in love with anaesthesia. I did the obligatory 1 year of overseas training in the UK. I got my specialist qualifications both with the Irish College and the Australian College. And in that training, I literally could not get my head around statistics. No matter what I read or what I was told, it just went round and round in circles. So the first thing I wanted to do, knowing I wanted to do research, was I wanted proper training. So I went and enrolled in a part-time master degree in public health and majored in statistics and epidemiology. Two things happened with that. Firstly, I learnt properly what all that information was and how to apply it and use it in research. But equally importantly, I developed contacts, mentors, collaborative groups and others who could value add to my ideas and thinking, but equally in the future, the research. And I cannot overstate the importance of that. It was so important. And I think for all researchers, by the way, but particularly clinical researchers. I did a doctorate early on because I was driven and motivated, had some level of support. The department I worked in as a specialist, the Alfred Hospital Department of Anaesthesia at the time, had published one paper in the previous 30 years. One paper. And I went into that as a young, enthusiastic researcher, driven and wanting to do research, and I had to grow that. I had to develop it. There was no one in there, but there was plenty of support, mentorship, guidance in the School of Public Health and others who were doing research and other specialties that were doing research. And I tapped into that very early on and continue to do so, and it's been the most enjoyable part of my career. The collaborative, team-based spirit of research is fantastic. Now, you might wonder what that weird photo is. I got an honorary doctorate in Sweden a couple of years ago, and the outfits are fantastic. So there you go. Right, so I'll take you back to 1996 just for a moment. So as I described, I was driven, I was young, and I wanted to do my first big trial. And I was a CIA on an NHMRC grant, and that's my whole track record. Right there, 12 publications. We got that grant, a big grant, the biggest grant in our specialty ever from NHMRC, to do a trial that some people said was impossible, could never be done. It wasn't really because of me, although I was driven and I could connect with people and bring in others into the group. It was because of other people, and I'll explain that in just a moment. So back in 1996, I was an anaesthetist working with a professor of surgery who was rather pompous. I liked the intellectual challenge working with him. He had a very low opinion of anaesthetists as researchers, and I had to wear that because that was the reality. But I read this paper in The Lancet by Richard Horton, who's still the editor-in-chief of The Lancet, who I now know. And in this editorial, he wrote that only 7% of papers in surgical journals are randomised controlled trials, and pointing out that case series provide the weakest evidence for assessing the efficacy of a treatment, and to retain their academic reputations, surgeons must plan randomised trial. Now, did I have a field day with a professor of surgery? I thought that was fantastic. I finished the day, was walking down the corridor of the hospital, and it suddenly dawned on me that that criticism applied equally and even more so to my specialty. That I had to contribute to improving the type of research that was being done in our specialty. So the big trial that we were considering and I wanted to do was based on a paper that had been published quite a few years earlier that completely changed anaesthesia practice around the world. The authors of the paper, Mark Yeager, David Glass and others, who are from Dartmouth Hitchcock in New Hampshire, beautiful part of the US, who have also come to know, by the way, which is another spin-off thing. Actually, I'll tell you one other thing. I've been to just about every country in the world. I've spoken at major conferences in every continent of the world except for Antarctica, but I've got that on my bucket list. And all of it is funded by other people. So you fly over there and get looked after. So if you do research, you can have a great life travelling the world. Now, back to this study for a moment. So these are the main findings of the study. So it was people having high-risk abdominal surgery, randomised in a single hospital to a combined general anaesthetic with epidural analgesia, pain relief, versus a general anaesthetic alone treated with morphine painkillers during and after surgery. And these are the findings. Only 53 patients, using the wrong statistics to get a p-value of 0.04, but nevertheless, significant improvements in outcome with the combined general anaesthesia epidural group. This changed practice around the world. I knew, because of my training, my research training, that this was simply highly unlikely to be true. And why would you change practice on the basis of what is really quite weak research? Even though it is a randomised controlled trial, which is an important feature, I think, in many studies. And it's now been cited over 600 times. So it was high impact through the decade that followed. We wanted to replicate that study. And we were supported in part by an editorial that came out in the same issue of that journal by a surgeon, Bernard McPeak from Harvard, who made this distinction between efficacy and effectiveness in clinical studies. I didn't fully appreciate this at the time, but again, another penny dropped, and accepted and agreed with the fact that if we are going to change practice, we would need to first replicate that study, but secondly, demonstrate that it's generalisable, that it works in a range of settings beyond one hospital in a nice part of America. So we set up to do that large trial. We were told by everybody it was impossible. No one had ever done a large multi-centre randomised trial in anaesthesia of this kind of thing. We worked with Conrad Radmanzik, sadly who's now passed away, who was a marvellous, wonderful epidemiologist from UWA, and he guided us in that study, and that's the reason we got that grant. It was not me at all. It was Conrad as a mentor that led us through it all. And we eventually published the definitive paper in The Lancet in 2002. It's had over 1,000 citations. We then went on to do another bigger and much better randomised controlled trials published in very big journals. That one there in The Lancet, we enrolled 7,000 patients around the world. In the last 3 years, we've had papers in the New England Journal of Medicine describing our big trials. High impact, important study. Our trials network are currently conducting 4 very large, all NHMRC funded trials, enrolling 20,000 patients having different types of surgery. So that's my career story. Get the extra training and skills, develop collaborations and partnerships, think big, start small and build up bit by bit, and do not give up. Never give up. You can succeed if you go about it in the right way. Now, to just briefly run over about how you design a trial. And this was our most recent trial. So there are worldwide guidelines about how much intravenous fluid should be used for patients having a major surgery, particularly major abdominal surgery. 300 million operations happen every year around the world. 300 million. 20% have serious complications that are life-threatening. Around about 5% die. It's one of the biggest causes of deaths around the world that's only now becoming to get onto the World Health Organization priority list. And these guidelines were saying that patients, in fact, should be giving less IV fluid during and after surgery. We should aim for zero balance, not too much fluid, because it's bad for tissue healing and so on. Now, I'm an anaesthetist. The problem with that, if we use this restrictive IV fluid regimen, we're going to get more low blood pressure, less urine output, and have to deal with that another way or ignore the problem. And I've spent all my life, from medical student beyond, saying you can't ignore low blood pressure. You need to treat it. It causes other problems. So if we're going to treat it differently, we add extra cost and new harms or potential problems. So you need to do a randomised trial. So the first thing we did was a systematic review and meta-analysis that showed that indeed the evidence was suggesting that you could get less serious complications, possibly lower mortality, but the p-value was not statistically significant based on a total of 11 events in the worldwide literature on that question of which there were international guidelines. It's just bizarre. It drives me nuts. We then did a survey of practice, and we asked specialists all over Australia and New Zealand, would you like to be involved in a trial? What do you believe is the right amount of fluid to use? And we got everything, right across the board, complete variations of practice. We simply didn't know the answer. We then designed up the big trial, which is the big relief trial, enrolling 3,000 patients randomised to a restrictive versus liberal fluid, a very simple trial designed. We followed patients out to 1 year after surgery, looking at disability-free survival to see if it really matters overall. We did a pilot study to show that the trial would work, and in fact we could get good group separation in the study, and the trial was feasible. All hospital staff could follow the protocol pretty well. We got good group separation in the fluids in that, and then we went to NHMRC. We've done all this background work. We believe this is a clinically important question. Give us lots of money. Now, the NHMRC has criteria to fund research. And the bottom line is you don't want to end up with a score of 5, 4, 3, 2, and definitely not 1. You need to aim to get a 7 to be guaranteed of funding, and it's extremely difficult. A 6 will get you over the line. It's a tough field to go into. But we applied for that grant. In fact, we got a letter back from NHMRC at the lovely time of year, which begins with those lovely words, "I am pleased to advise." The other alternative is, I regret to inform you. It's a terrible opening to any email. We, in fact, scored incredibly highly for that simple trial. It was the highest ranked project in the whole of the NHMRC, 4,500 applications in that year. And I got to shake the Health Minister's hands. Sadly, it was Peter Dutton. Nevertheless, we did that trial, 3,000 patients, 47 hospitals, 7 countries around the world, on time, as planned, and published in the New England Journal of Medicine just 2 months ago. And the reason it was because we, in fact, could demonstrate the importance that what we believe was the best group in the world, in Australia, that could do that study, that we could do the study, that we had all the background work and had success. Thanks very much.